Welcome to Chapter 17, where we will be covering pediatric emergencies, where many things can go wrong before we realize it. So some of the competencies that we need to be familiar with or have acquired per the National EMS Education Standard, considering special patient populations. We need to recognize and manage life threats based on our assessment findings for a patient with special needs while awaiting for additional emergency response. We need to recognize and manage life threats based on our assessments of the patient with a medical emergency. And then we also need to understand the anatomy and physiology or function of the upper airway, heart, vessels, lungs, blood, skin, muscles, and bones, using that as a foundation of our emergency care. Pediatrics, so age-related assessment findings and age-related assessment and treatment modifications for pediatric specific major diseases and or emergencies, looking at upper airway, lower airway, respiratory shock, seizures, and SIDS, or sudden infant death, and recognize and report abuse and neglect, and how to manage those situations as well. So our respiratory or pediatric respiratory system, we're going to look at our anatomy, signs and symptoms, and management of respiratory emergencies, including those that affect both the upper and the lower airways. So sudden illnesses and medical emergencies are very common in children and infants. They have a tendency to what's called plateau. They maintain or they compensate for a prolonged period of time until they can no longer do that any longer, and they just kind of tend to dive off the deep end and crash on us. Whereas adults, they give us a lot of leading indicators to let us know or indicate to us that they're going downhill. Children, we seldom see those indicators, and then all of a sudden we have somewhat of a healthy child, or what would appear to be a healthy child, to a very sick child. So there are several anatomic differences between adults and children, and that require special knowledge and skills to assess and treat children and infants. Respiratory care for children is extremely important, as we know that children and infants are predominantly respiratory driven and often go into respiratory arrest preceding cardiac arrest, whereas adults typically go into cardiac arrest as a primary and respiratory arrest, kind of a coexistence, so to speak. Emergency medical responders should learn some basic information and treatment for common pediatric emergencies, which we will be covering in this chapter. Managing a pediatric emergency can be one of the most stressful situations you are faced with as an emergency medical responder, an EMT, an advanced EMT, or even a paramedic, or even as a firefighter. In an atmosphere where everyone involved is tense, you must remain calm and behave in a controlled and professional manner. And even if you don't know what to do or what the right decision is, we still need to project that we do. We don't have to lie about it and say that we do, but just that general presentation of calm and professionalism will project that. EMS personnel should often have mixed feelings when treating a child. Unless you are prepared, your anxiety and your fear may interfere with your ability to deliver proper care. Then also, when we are dealing with pediatric emergencies, we also have the parents to contend with, and sometimes they can be just as much of a patient as the child. They can either be allies or a potential problem. So talk to both the parents and the child. Nothing kind of infuriates a parent when they are excluded from a discussion about their child. And then helpful parents can tell you how the children behave or behavior is different than their normal baseline. Are they acting abnormal? Or is this their usual behavior? Is this how they normally respond or react to stressful events? And then also remember, children may get their behavioral cues from their parents. Calm parents and ask for their assistance in calming a child. If possible, let a parent hold their child, and to try to build a rapport with that child. Introduce yourself to that child as part of rapport building. Tell them your name, ask them for theirs, and use their name as you explain to them what you are doing. Talk to them first person. Get on their level or slightly below. You can do this by kneeling or squatting or sitting down next to them and establish eye contact. Ask them simple questions. Don't overcomplicate things, especially when it's talking about pain or the way they feel, if they're having nausea or just feeling general sickness. Tell the patient what you're going to do. Don't lie to them. Be honest. If something's going to hurt or you think it might be uncomfortable for them, tell them, this blood pressure is going to cuff is going to squeeze on your arm. It might be a little tight. Or if you have to check a blood sugar, things like that. In talking to a child, you can also request for them to help you. And this helps sometimes get them engaged and further build that rapport. Some agencies do carry like little teddy bears or other stuffed animals on their units or in their trucks to help keep them calm while you're assessing them. If your agency doesn't have that, maybe it's something that would be worth considering. So some key differences between children and adults. A child's airway is smaller in relation to the rest of the body compared to an adult's airway. A child's tongue is proportionately larger than an adult's. The upper airway is more flexible and more malleable than an adult. And for at least the first 6 months of their lives, infants can breathe only through their noses. When demands on a child's respiratory system change, a child is able to quickly compensate by increasing breathing efforts. Infants and children have limited ability to compensate for changes in temperature as compared to adults. Rapid changes in temperature in children is one of the leading causes for febrile seizure activity. Children also lose heat relatively quicker than adults do, and so keep pediatric patients warm if they become chilled. But the biggest key there is to prevent the rapid temperature change, whether it's hot or cold. You can see here in this schematic or this picture here is the comparison of a child's tongue to an adult's tongue proportionately. So examination of a pediatric patient should always consist of these 5 same steps in your assessment sequence, the same as the adult, starting with your scene size up to ensure scene safety for you, yourself, your partner, and your patient. Complete your primary assessment. Form a general impression of the patient. This is typically done upon entering the room or when you first make eye contact with the patient. You can quickly determine, are they conscious? Are they breathing? Do they appear to be in distress? What's their skin color? What other compounding factors around the patient are there, whether it be just simply in a residence like their bedroom or an accident scene. You can determine the patient's level of responsiveness, and you can also assess their airway by simply seeing, are they breathing and what's their effort of breathing. Complete your secondary assessment by examining the child from head to toe. Remember to talk to them and explain to them what you are doing and why. And then obtain a medical history. This is typically more done through a caregiver or the parent. Children oftentimes don't really know much about their own medical history. And then perform reassessments as needed. So here you see in this picture on the bottom of your screen the pediatric assessment triangle. We talk about the 3 components of the pediatric assessment triangle. We have appearance, work of breathing, and circulation of skin or to the skin. This is going to be their skin color and their capillary refill. This can be used to assess a child from a distance. This is part of your scene size up or your general impression portion of your assessment. A lot of times if you arrive on the scene of a wreck, you can see this from several yards away from the patient, or even while you're still in your ambulance. Same thing when you come into a patient's bedroom or the house, you can just take one look at them, and you can use this assessment triangle to quickly ascertain the general impression. Is this child sick or are they not sick? So appearance. This is an indicator of how well the heart, lungs, and central nervous system are working. It compares a child's appearance with what you would expect for a healthy child. Assess eye contact, muscle tone, and skin color. So eye contact is, do they track you? Do they look at you when you walk into the room? You a stranger? Are they paying attention to that? Or are they completely oblivious that you're there? Muscle tone, skin color. Skin color is going to give you some indicators on how they're perfusing. Are they flushed? Are they pale? Does their skin look normal colored? And then also muscle tone. Do they have retractions? Are they guarding? Are they using their accessory muscles to support themselves? And reassess regularly because appearance can change very rapidly. So here on the left side of your screen are some examples for your characteristics in appearance. If they're moving, a healthy reaction is moving vigorously on movement. Unhealthy reaction, limp, listless, flaccid. And then you have interaction, reassurance, eye movement, speech, and cry. This chart is also in your textbook that you can take a look at later. Here we have breathing. Assessing work of breathing is a more accurate indicator of a patient's condition than merely determining the rate of their respirations. It is determined by measuring abnormal breath sounds, abnormal posturing or positioning, retractions of the neck or chest, flaring of the nostrils. This assessment can be made without touching a child and can be done from across the room. And then circulation to your skin or to the patient's skin. So paleness, white or pale skin indicates inadequate blood flow to the skin. Mottling is patchy skin discoloration. This is caused by too much or too little circulation to the skin. And then cyanosis, which is a bluish discoloration. It is caused by low levels of oxygen in the blood. The pediatric assessment triangle should be used with other parts of the patient assessment sequence, not as a freestanding assessment tool, but as in conjunction to the rest of your vital assessments. To calculate respiratory rate of a child, you shouldn't count respirations, or you should count respirations for at least 30 seconds, and then multiply that by 2. If you have a hard time counting, you can count to 60, but it really should be at least 30 times a minute, or 30 times. Count up to 30 seconds. Look for signs of respiratory distress, noisy breathing, snoring, crowing, grunting or wheezing. And you can use these to assess how much work the child is doing to breathe. Check for retractions in the neck and the chest, and look for flaring nostrils. Your pulse rate, on the left side of your screen, there's a chart for your general averages based on age to heart rate and respirations per minute. A normal pulse rate for a child is faster than an adult's normal rate. And for a child younger than 1 year, you want to palpate the brachial pulse. A radial pulse, you may be able to feel it, but it's going to be very weak and oftentimes hard to find. And it's going to be the least accurate. So just go where your 2 fingers can fit nicely into that brachial notch and get your pulse from there. Okay, so high temperatures are accompanied by flushed and red skin, sweating and restlessness. To feel a high temperature, touch the child's chest and head. A child's heart rate will increase with each degree of temperature rise in an effort to cool their own body down. It is important to open and maintain a child's airway to ventilate adequately in any child with respiratory problems. Problems that can lead to respiratory arrest followed by cardiac arrest are specific causes of cardiopulmonary arrest in children include suffocation caused by aspiration of a foreign body, infections of the airway such as croup, epiglottitis, SIDS or sudden infant death syndrome, accidental poisonings, and injuries around the head and neck. So treating respiratory emergencies in infants and children. To open the airway, use the head tilt chin lift maneuver on children who have not sustained an injury to the neck or head. Of course, if we don't know if there's been an injury, we're going to go to the jaw thrust maneuver. Do not hyperextend the child's neck when you tilt it back, and use a neutral or slight sniffing position. Place a folded towel under the child's shoulders to help maintain that position. Children's heads are also somewhat proportionately larger compared to their body than, say, in an adult. If the possibility of an injury to the head or neck exists, try the jaw thrust maneuver or the modified jaw thrust maneuver. Perform basic life support. You must use specific techniques when you perform CPR on a child. CPR for children 1 year of age to onset of puberty is different from an adult CPR in three ways. If you are alone and EMS has not been called yet, you should perform 5 cycles or 2 minutes of CPR before going to activate EMS or to call 911. Use the heel of one hand or 2 hands to perform chest compressions, depending on the size of the child, and compress the sternum at least 1/3 the depth of the chest. CPR for infants that are less than a year of age have 5 differences than adult CPR. First, we want to check for responsiveness by tapping the infant's foot or gently shaking their shoulder. Check for a brachial pulse. Use your middle finger and your ring fingers to compress the sternum just below the nipple line. Compress the sternum at least 1/3 the depth of the chest. Give gentle rescue breaths using mouth-to-mouth and nose ventilations if you do not have a face mask or BVM. And when we do this, we're breathing in just enough to achieve the beginning of chest rise. We don't want to hyperinflate the chest either. Suctioning. When a patient's airway is blocked by secretions, vomitus or blood, you should clear it initially by turning the patient on his or her side and use your gloved fingers to scoop out as much of the substance as possible. Now, this is only in small children and infants. You can use suctioning to remove the foreign substances that cannot be removed with your gloved finger. Suctioning can be a life-saving procedure. The procedure used for suctioning infants and children is generally the same as for adults, with some exceptions. Use a tonsil tip or a rigid tip suction mouth, and do not insert it any farther than you can see. Use a flexible catheter to suction the nose of a child and set the suction on the low to medium power. Use the bulb syringe to suction the nose of an infant, and never suction for more than 5 seconds at one time. Try to ventilate and reoxygenate the patient before repeating suction. Part of the reasoning for this is that prolonged suctioning can actually cause a profound decrease in heart rate or cause bradycardia. Also, a lot of times going further in to where you cannot see because the airway is so much smaller, we run a much higher risk of further lodging a foreign body into the airway. So airway adjuncts for infants and children. Oral airways can maintain an open airway after you have opened the patient's airway by manual means. And EMRs rarely actually use nasal airways for children, so your OPAs are going to be your primary go-to. You can usually relieve a mild airway obstruction by placing the child on his or her back and tilting the head and lifting the chin in usual manner. An airway that is blocked by an aspirated foreign object is a common problem in small children or young children. Remove the object if it is clearly visible in the mouth and can be easily removed. If not, do not attempt to remove the object as long as the child can still breathe air around the object. Trying to remove an object that is partially blocking a child's airway can push it further down and causing a more severe airway blockage. Children should be transported to the emergency department. Talk constantly to the child and consistently. Keep your story straight about what you are doing to provide comfort to that child and reduce his or her terror. Most of the time, parents are able to realize the seriousness of the situation, redirect their emotions, and work with you to reassure and calm that patient or that child. Administer oxygen if it is available, and if you are trained to use it or allowed to per protocol. Place the oxygen mask over the patient's or the child's mouth and nose, and do not try to get an airtight seal. Hold it about 1 to 2 inches away from the child's face. If they won't tolerate that or that air mask, you can try simple blow-by, which would be just taking oxygen tubing and kind of doing the same thing, holding somewhere near 1 to 2 inches away from their face, and that'll kind of increase the oxygen percentage. A complete airway obstruction or a severe airway obstruction is a serious emergency for children. This involves poor air exchange, increased breathing difficulty, silent cough, inability to talk, or sometimes no air movement whatsoever. Use the Heimlich maneuver because this creates enough force and energy to expel most objects that would cause a complete airway obstruction. The steps to relieving an airway obstruction in a child are fairly similar or pretty much the same as to an adult, with some slight differences. When opening the airway for a child, you want to use the tilt the head back slightly past the neutral position or a sniffing position. And if you are by yourself and with a child who has an airway obstruction and they become unresponsive, lower them to the ground or to a hard surface, perform 5 cycles of CPR. That's about 2 minutes of CPR prior to going to activate the 911 system or call for EMS. An infant younger than 1 year of age is very fragile. If you suspect an airway obstruction, first assess the infant to determine whether any air exchange is occurring at all. If the infant is crying, the airway is not completely obstructed. If there's no air moving in or out of the infant's mouth or nose, suspect an airway obstruction. To relieve an airway obstruction in a conscious infant, use the combination of back slaps and chest thrust maneuver. Remember, we always want to start with the back slaps with the head downhill from the patient's torso. This allows gravity to kind of help with the movement of the obstruction towards exiting the airway. Place the infant in the face-down position over your arm and deliver your 5 back slaps forcefully between the infant's shoulder blades with the heel of your hand, and then turn them over and do your chest thrusts. You can see here on the bottom right hand of your screen an example of back slaps. Me personally, I would probably have the head a little bit lower than that, but that's a good example of what a back slap should look like. So now turn the patient face up by sandwiching the infant between your arms and your hands. Deliver your 5 chest thrusts in the middle of the sternum with 2 fingers, and then repeat a series of back slaps and chest thrusts until the foreign body is expelled or until the infant becomes unresponsive. If the infant becomes unresponsive, continue with these steps. Ensure that CPR has been activated or EMS has been activated, and then begin CPR. Continue CPR until personnel with more advanced training and EMS skills have arrived. If small round objects do not become airway obstructions, they usually pass uneventfully through a child and are eliminated in a bowel movement. Sharp or straight objects are dangerous if swallowed, and arrange for prompt transport, and try to keep the child as calm and as still as possible. So signs and symptoms of respiratory distress. Respiratory distress indicates that a child has a serious problem that requires immediate medical attention. A breathing rate of more than 60 breaths per minute in infants, or a breathing rate of more than 30 to 40 breaths per minute in children, nasal flaring on each breath, retraction of skin between the ribs and around the neck muscles, and then the sound of stridor, cyanosis of the skin, or where the skin around the lips is turning blue, altered mental status, combativeness or restlessness. Try to determine the cause when you're moving to treat the respiratory distress. Support the child's respirations by placing the child in a comfortable position, usually sitting or upright sitting position. Keep the child as calm as possible by letting the parent hold the child if practical. Prepare to administer oxygen if it is available and if you are trained to use it. Monitor their vital signs and arrange for prompt transport. Remember, a child in distress, we don't want to force the oxygen to them, so if they don't want an oxygen mask on their face or around their face, we can attempt to do simple blow-by maneuvers, but the biggest key thing there is keeping the child calm. Respiratory failure often results as respiratory distress proceeds. So signs of respiratory failure include breathing rate lower or fewer than 20 breaths per minute in an infant, or a breathing rate fewer than 10 breaths per minute in a child. Limp muscle tone, unresponsiveness, decreased or absent heart rate, weak or absent distal pulses. Remember, a child in respiratory failure is on the verge of experiencing respiratory and cardiac arrest. So support the respirations by performing mouth-to-mask ventilations if needed. Administer oxygen if it's available. And begin chest compressions if the heart rate is absent or it is less than 60 beats per minute. Arrange for prompt transport. The most common cause of circulatory failure in children is respiratory failure. Uncorrected circulatory failure can lead to cardiac arrest. And increased heart rate, pale or bluish skin, and changes in mental status indicate circulatory failure. If the heart rate is more than 60 beats per minute, complete a patient assessment, support ventilations, administer oxygen, observe vital signs. If the heart rate is less than 60 beats per minute and there are signs and symptoms of poor circulation, begin chest compressions and rescue breathing. This would be for an infant. Altered mental status can be caused by low blood sugar, poisoning, post-seizure, or a postictal state, infection, head trauma, or decreased oxygen levels. So your assessment, complete your patient assessment, pay particular attention to the patient's initial vital signs, calm the patient and the patient's family, be prepared to support their ABCs, and place an unconscious patient in the recovery position. A respiratory problem can range from a minor cold to complete blockage of the airway. Because infants breathe primarily through their noses, even a minor cold can cause breathing difficulties. Emergency medical responders should be able to recognize 3 serious conditions. We have asthma, croup, and epiglottitis. Asthma, a child who has asthma is usually already being treated for SAME by a physician and is taking a prescribed inhaler. Asthma is caused by a spasm or constriction and inflammation of the smaller airways in the lungs and usually produces a characteristic wheezing sound. A child who is experiencing an asthma attack is in obvious respiratory distress. The primary treatment consists of calming and reassuring both the parents and the child. Place them in the sitting position to make the breathing more comfortable. Pursed lip breathing relieves some internal lung pressure that causes an asthma attack. You can see here is an example of this picture of this child doing the pursed lip breathing. If a child has an asthma medication but has not been administered, help the parent administer the medication. If the child's physician is not available, arrange for prompt transport. Croup. Infection of the upper airway that occurs mainly in children between 6 months and 6 years of age. Results in a hoarse whooping noise during inhalation and a seal-like bark or barking cough. It often occurs in cooler climates. A lack of fright and willingness to lie down are important signs that distinguish croup from epiglottitis. If EMS unit is delayed, turn on hot water in the shower and close the bathroom door. That more moist air will help relax the vocal cords. And epiglottitis is severe inflammation of the epiglottis. The flap is so inflamed and swollen that air movement into the trachea is completely or almost completely blocked, and usually occurs in children between ages 3 and 6 years old who are not vaccinated against this disease. Signs and symptoms: the child is usually sitting upright, cannot swallow. They are not coughing, but they are drooling, and is anxious and frightened. The chin is usually thrust forward. Try to make the child as comfortable as possible. Keep everyone calm, including yourself. Administer oxygen and arrange for prompt transport. And from experience with this, try to make that transport as quiet and calm as possible. As expedited, but as quiet and as calm as possible. External stimulation like lights and sirens or heavy traffic, shaking and moving of the truck, it all increases anxiety and can cause further exacerbation of that epiglottitis. Drowning is caused by submersion in water and initially causes respiratory arrests. It's the second most common cause of accidental death among children 5 years of age and younger in the United States. Remember, don't put yourself in danger as you attempt a rescue. Signs and symptoms include lack of breathing and no pulses. Oftentimes when we arrive on scene to the scene of a pediatric or a child drowning, they have already been removed from the water. But remember your personal safety. Treatment, you want to assess your ABCs. Turn the child onto one side and allow the water to drain out of the child's mouth. Use suction if it is available, and start rescue breathing if necessary. Administer supplemental oxygen. If no pulse is present, start compressions, chest compressions. Stabilize the neck as needed. To reduce risk of hypothermia, dry the child and cover him or her with dry blankets and arrange for prompt transport. Heat stroke is a serious and potentially life-threatening condition, and they should be transported to an emergency department as expeditedly as possible. Remove the child's clothing, sponge wet water over them, and fan them. You may wrap the child in wet sheets to speed up evaporation and cooling process. But remember when you're doing this to check the temperature of those sheets, because they can quickly go from helping active cooling to insulation barrier. So put the wet sheets on them, keep them there for a few 10 seconds or so, remove them, let that evaporation happen, and then arrange for rapid transport. High fevers are common in children because the temperature regulating mechanism in children has not fully developed yet. Very high temperature can occur very quickly. Most children can tolerate temperatures as high as up to 104 degrees Fahrenheit. So if you're assessing a patient or a child with a high temperature, uncover them so that the body heat can escape. Attempt to reduce that high temperature by undressing them, fan them to cool them down, protect the child during any seizure that might occur, and make certain that normal breathing resumes after a seizure. Also take special precautions not to cool them too rapidly. One of our biggest enemies here is that rapid temperature change. And also, further on that is to make sure that you stop cooling them when they have reached an appropriate temperature. We don't want to make them hypothermic. Seizures can result from high fever or from disorders such as epilepsy, and can vary in intensity from simple, momentary staring spells to generalized or grand mal seizures that involve full body tremors. They're not usually dangerous, The most dangerous thing about seizure is actual trauma with them actually hitting something that is an object that is close to them or a hard floor. So during a seizure, they will lose consciousness or appear to lose consciousness. The eyes may roll back in the head. Teeth may become clenched. The body shakes with severe jerking movements, and their skin may turn pale and cyanotic or blue. Sometimes the child will lose their bladder or bowel control. Place them on the floor or a bed to prevent injury, protecting their head, and maintain an adequate airway after the seizure has ended. Maintain an adequate airway after the seizure ends. Provide supplemental oxygen and arrange for prompt transport. Monitor their airway, breathing, and circulation, and cool the patient if they have a high fever after the seizure has ended. So vomiting and diarrhea are usually caused by gastrointestinal infections. Prolonged vomiting and diarrhea may produce severe dehydration. As humans, we are profoundly dehydrated at the start of every day. None of us drink enough water, so we're always slightly dehydrated, and vomiting and diarrhea dehydrates us the fastest of any other means. Dehydrated child is lethargic and has very dry skin. Hospitalization may be required to replace the fluids through IV fluids. If you suspect that a child may be dehydrated, go ahead and arrange for transport so that they can get that fluid resuscitation at the hospital. One of the most serious causes of abdominal pain in children is appendicitis. Appendicitis is often seen in people who are between 10 and 25 years of age. It is a cramping pain in the belly button area, moving to the lower right quadrant of the abdomen, becoming steady and more severe. Usually a child is nauseated and has no appetite and occasionally will vomit. Treat every child with a sore or tender abdomen as an emergency and arrange for transport. Young children are very curious and often like to sample contents of brightly colored bottles or cans or berries or pills. Two of the most common types of poisoning in children are those caused by ingestion or absorption. An ingested poison is taken by mouth. A child who has ingested a poison may have the following signs or symptoms. So chemical burns, odors or stains around the mouth, nausea, vomiting, abdominal pain, or even diarrhea. Later symptoms down the road may include abnormal or decreased respirations, unconsciousness, seizures. If you believe a child has ingested a poisonous substance, take the following steps. Try to identify the poison if you can, and send the bottle or container along with the child to the emergency department. If there's another substance like a plant or something else, see if you can gather up a sample of that you feel that might have been the source of the poisoning. Any spilled tablets, and replace them into the bottle so that they can be counted. So if you have an open medicine bottle that's been spilled on the floor, try to get as many of those back in there as you can find. Contact local poison control. If the transport is delayed, you may need to give the child large amounts of water or administer activated charcoal. Monitor if your system still has it in their protocols. Monitor the child's breathing and pulse closely and arrange for that prompt transport. Absorption occurs when a substance or a poisonous substance is absorbed through the patient's skin into their body. A child who has absorbed a poison may have localized symptoms like skin irritation or burning where that absorption had occurred, or systemic signs and symptoms including nausea, vomiting, dizziness, and sometimes shock. Ensure that the child is no longer in contact with the poisonous substance. Protect yourself from exposure and call for specifically trained personnel if indicated. Remove the child's clothing if you think it could be contaminated. Brush off any dry chemical that they have, and then wash the child with copious amounts of water for at least 20 minutes, taking special attention to not drown them. Wash off any liquid poisons by flushing with water for at least 20 minutes. Again, copious amounts. Well, we don't want to just dribble water on. We want to actually flush it off. Try to identify, and the reason we use copious amounts of water, again, as mentioned in the poisoning chapter, is in case this substance is reactive to water. We don't want to use a small amount of water to allow that reaction to happen. We want to use as much water as we can safely to get it off and away from the patient. If anyone's ever heard that saying, dilution is the solution, it really does help with many things. Try to identify the poison and then monitor the child for changes in respiratory rate or pulse rate. If the child has vomited, see if you can collect a sample and send it with the patient to the hospital so that they can try to attempt to identify it in the lab there. Sudden infant death syndrome, also known as crib death, is a condition frequently mistaken for child abuse. It's sudden and unexpected death of an apparently healthy infant. SIDS usually occurs in infants between ages of 3 weeks and 7 months old. There's no adequate scientific explanation to explain SIDS. If the infant is still warm, go ahead and start CPR and continue until help arrives. In many cases, the infant has been dead for several hours and the body is cold and lifeless. If you are in a situation where you initiate CPR, go ahead and place them on an AED and continue CPR even if it does not advise for a shock. Of course, if a shock is advised, go ahead and defibrillate or shock. Do not mistake large bruise-like blotches on an infant's body for signs of child abuse, especially in the instance of extended downtime. Sometimes this happens in the middle of the night. Parents come in and check on the child, and the child's been dead for hours. Splotches are caused by pooling of the infant's blood after death. Follow your local protocol in your community for management of the deceased patients. Be compassionate and supportive with the parents. It's probably one of the hardest things that anyone could ever go through in their entire life, and at this point they are now your patients, and the infant is no longer a patient of yours. Pediatric trauma. Trauma is the #1 killer of children. Treat an injured patient or child as you would an injured adult, but remember the following differences. A child cannot communicate symptoms as well as an adult can. You might have to work a little bit harder at deciphering what they're trying to tell you. They may be shy or overwhelmed by adult rescuers. Everyone in the room is now a stranger, and they also hurt. So it is important to develop a good relationship quickly to reduce the child's fear and anxiety. You may need to adapt materials and equipment to the child's size, improvise and adapt and overcome. A child does not show signs and symptoms of shock as early as an adult, but can progress into severe shock very quickly. If you remember a few slides ago, I mentioned the plateau effect, or they compensate, and then they drop. It's much the same with trauma as it is in respiratory. They will compensate until they no longer can, and then they will just fall off the deep end. Patterns of injury sustained by children will reflect 3 factors: the type of trauma they experienced, the activity causing the injury, and child's anatomy. For motor vehicle crashes, unrestrained patients tend to have more head and neck injuries, while restrained patients often suffer head, spinal, and abdominal injuries. Bicycle accidents, children often suffer head, spinal, and abdominal injury and extremity injuries in bicycle accidents. Use of bicycle helmets can greatly reduce the number of severity and head injuries. Also, another thing with bicycle accidents is impalement. A lot of the rubber grips on the handlebars, the ends, get torn off from children throwing the bikes on the ground, and they getting rubbed, and they actually become a little hollow, sharp metal tubes. I personally have had a couple of those where the child was riding through a yard, hit a depression in the ground or something, fell down, and the bicycle handle actually impaled their abdomen, and they actually had abdominal injuries due to that. So, if they have thick clothing or things like that, always expose the patient and look for those types of injuries as well. Children hit by cars. Pedestrians often sustain chest, abdominal, thigh, and head injuries. And falls from height or diving accidents tend to cause head and spinal injuries, as well as extremity injuries. Burns are a major cause of injuries to children as well. Sports activities cause a wide variety of injuries depending on the type of sports. Treatment, regardless of cause of injury, maintain your ABCs, stop any severe bleeding, treat the patient for shock, conduct a full body secondary assessment, looking for those hidden injuries, and stabilize all injuries that you find. If the patient has head lacerations, treat the wounds with direct pressure and appropriate managing techniques. Traumatic shock in children. Children show shock symptoms much more slowly than adults do. Remember the plateau effect, but they progress through the stages of shock quickly. If signs of shock are present, the child is already in severe shock and they are already on the edge. Signs and symptoms: cool, clammy skin, rapid weak pulse, rapid and or shallow respirations. Seizures are relatively common in children who have sustained a serious head injury. The greatest dangers to any patient who has sustained trauma are airway obstruction and hemorrhage. When caring for an injured child, open and maintain the airway, control the bleeding, and arrange for prompt transport. Car seats and children. If you find a child properly restrained in the car seat after an MVA or motor vehicle accident, leave the child in the car seat until the ambulance arrives. In some cases, the child can be transported to the hospital and secured in a car seat. Exceptions to that is if the car seat is actually impeding patient care, or if there are injuries where airway injuries where you just absolutely have to get to that patient or stop some sort of hemorrhage or something like that. Child abuse. Child abuse is not limited to any ethnic, social, or economic group or to families with any particular level of education. Suspect abuse if the child's injuries do not match the story you are told about how the injuries occurred. An abused child may have many visible injuries at different stages of healing. Be concerned if the child is withdrawn, fearful, or hostile, and is unwilling to discuss how the injuries occurred. Going back to the different stages of healing, look at the child's environment and what their lifestyle is like as well. That can indicate whether or not these are naturally occurring just from them being rough and tough and tumble children, or if this could actually be an abusive situation. Treat children's injuries, and if you are suspicious that the incident may involve child abuse, ensure that the safety of the child. Don't be accusative of the parents. Do everything you can to steer away from confrontation while on scene. Signs and symptoms of child abuse may include multiple fractures, bruises in various stages of healing, human bites, burns, reports of bizarre accidents that do not seem to have a logical explanation. Transport the child to the appropriate medical facility. If the parents object, summon law enforcement. Try to do so quietly, as to try to avoid creating those confrontational situations. Neglect is another form of child abuse. So children who are neglected are often dirty or too thin or appear developmentally delayed because of a lack of stimulation, lack of adult supervision, malnourishment, or a malnourished appearing child, unsafe living environment, untreated chronic illness are some signs and symptoms of neglect. Handle each situation in a non-judgmental manner, and know whom you need to contact to report suspected cases. When reporting these cases, you need to do, especially with child abuse and elderly abuse, but you yourself need to report it to the appropriate authorities, and you need to find out who it is. In our region here in Western North Carolina, that's law enforcement. So when we get to the hospital, we ourselves need to contact law enforcement. It's not enough for us to tell the nurse or the receiving physician that of our suspicions. We actually have to contact DSS and make them aware of that. Sexual assault of children. In addition to experiencing sexual assault, the child may have been beaten and may have other serious injuries. If you suspect sexual assault has occurred, obtain as much information as possible from the child and any witnesses. Providing a caring approach is extremely important, and you should take appropriate action to shield the child from onlookers. All victims of sexual assault should receive transport to the appropriate medical facility. You will respond to many calls that involve children. These calls tend to produce strong emotional reactions. You may feel especially angry or helpless when you suspect neglect or abuse of a child. You may need to talk about your frustrations with a counselor or with another member of your department following a serious pediatric call. It may be helpful to set up a critical incident stress debriefing session. By attending a debriefing session, you can express your feelings, learn some coping strategies, and maintain a healthy approach to future calls. Never be afraid to reach out for help or when you need someone to talk to or need advice. Okay, so let's summarize this chapter. Because anatomy of children and infants differs from that of adults, special knowledge and skills are needed to assess and treat pediatric patients. Because both a child and parents may be frightened and anxious, you must behave in a calm, controlled, and professional manner. A child's airway is smaller in relation to the rest of the body compared to an adult's airway, so secretions and swelling from illness or trauma can more easily block a child's airway. A child who is unresponsive, is lackluster, or appears ill should be evaluated extremely carefully because lack of activity and interest signals serious illness or injury. Three components of the pediatric triangle are overall appearance, work of breathing, and circulation to skin. It is important to open and maintain a patient's airway and to ventilate adequately. Any child with respiratory problems. Young children often obstruct their upper airway and their lower airway with foreign objects, such as small toys or candy. In a complete or severe airway obstruction in a conscious child, you should perform the Heimlich maneuver, and then if the child becomes unresponsive, perform CPR. To relieve an airway obstruction in an infant, use a combination of back slaps and chest thrusts. Two most common types of poisonings are ingestion and absorption. Ingestion taken by the mouth and absorption entering through the skin through direct contact. SIDS, or crib death, is unexpected death of an apparently healthy infant, generally between 3 and 7 months of age. Respiratory distress in children requires immediate attention. 3 serious respiratory problems in pediatric patients are asthma, croup, and epiglottitis. Other pediatric medical emergencies include drowning or submersion, heat-related illnesses such as heat stroke, high fevers, seizures, vomiting and diarrhea, and abdominal pain. Major trauma in children usually results in multiple system injuries. And if you suspect child abuse or sexual assault, You must transport the child to an appropriate medical facility and personally alert the proper authorities, which, like I said, in Western North Carolina is DSS and law enforcement. So we have a couple questions for review. The purpose of the pediatric assessment triangle is to A, guide the hands-on physical assessment, B, help you determine if the child's vital signs are appropriate, C, allow you to quickly form a general impression of the child, or D, help you remember systemic assessment process. The correct answer is C, to allow you to quickly form a general impression of the child. Next question, which of the following statements about SIDS is false? Is it A, it usually occurs in children between ages of 3 and 7 years. No adequate scientific explanation exists. It occurs in apparently healthy children. Or you should start CPR in a child if the child is still warm when you arrive. The correct answer is A. It usually occurs in children between ages of 3 and 7 years old. That is false because it's 3 and 7 months. Next question, which of the following is not a common respiratory condition in children? Is it A, asthma, B, epiglottitis, C, pneumonia, or D, croup? The answer is C, pneumonia. All right, and that's all we have for pediatric emergencies. Remember to take a look at your learning objectives back in your My Courses for a study guide. Use those as a study guide. Read Chapter 17. If you have any questions or comments, please email me or drop me a message in our class chat. Remember, with the class chat, you can also do private or direct messages. And we'll see you next time with Chapter 18 covering geriatric emergencies.